talking about inclusion criteria, most of the patients were good or intermediate risk patients in a lot of these clinical trials. So Susan, what's your approach to choosing the therapy for good or intermediate risk patients?
I tend to, like Paul very eloquently explained, I tend to wait until there's clear progression or having the clinical impression based on Memorial Sloan Kettering criteria or just your gut feeling as a clinician looking at the patient, that this patient, that the course of disease is going to be quite fast. So when the decision is made to treat patients, I think that the aim of the treatment, of course, is not to cure. We can still not cure patients. So the primary aim is to prolong life, but not to the extent, of course, that the quality of the life is very poor. So there should be a balance between side effects of treatment and improvement of overall survival. For intermediate and favorable risk patients, we tend to use the same TKIs, at least the group of TKIs. And for poor prognostic patients, in the past we tend to make a distinction and use the temsirolimus based on the ARC study. In honesty, although it's a very easy way of treating patients, it's not very toxic, it's easy, but it's an in-house patient treatment. More and more we were used to also treat those patients similar to the ones that have been classified as favorable or intermediate group risk patients. So in principle, all three risk group categories get the same treatment, which is first-line VEGF-R inhibitors. And we have done bevacizumab plus interferon. In honesty, I do think that it's a shame that bevacizumab alone was not a control arm in the pivotal trial, because I'm personally convinced that it's the bevacizumab and not so much the combination with interferon. But because the phase 3 trial was with the combination, I think that we should treat patients with the combination. And what we see worldwide, and in particular in Holland, is that the combination is used very rarely. And I think the only reason being that you have to administer BEV once every 2 weeks intravenously, and then interferon 3 weekly sub-Q, different side effects. It's just a little bit more cumbersome, and everybody likes to treat patients with just a prescription and oral compounds. That's what's being done. In the past, we've been using IL-2. Personally, I have very good experience with IL-2. I liked it a lot, although it's quite intensive. It's really intensive ward patients, but I like to do it, and I hardly slept because every 5 minutes I had to make adjustments because of hypertension, anuria, etc. But I still have patients that are cured, so I think it's a very good form of treatment, but it requires a whole setting in an ICU ward, so we tend not to give it any longer. I think in all of Holland, nobody, where I live and work, nobody's giving IL-2, but it's still, I think, it still stands as a treatment that can induce cure.
I agree.
To the extent of a lot of toxicity.
So I think the use of IL-2 and the interferon are declining, I think. And so, and I agree that bevacizumab and interferon aren't as commonly used because of the combination. So we're left with sunitinib.